Hey y'all, so I got out of my haircut, because my hair was driving me nuts, and I shaved it because I'm tired of watching my hair thin out, and it's less distressing if I shave it. So when I talk about being too far gone, I don't really know what else to call it. This is what I mean. This is how deep my voice is. It's gotten deeper over time, and it's settled. This is what I mean by hair loss. And it just keeps getting worse. It keeps thinning. It keeps receding backwards. And I'm not exactly sure that's coming back. Those are the main things when I talk about being androgenized to a point of no return. I really don't see those being fixable. So that's when I talk about, just kind of staying how I am, regardless of how I feel. That's why, just because I don't really see me personally being able to come back from what's happened so far. So I hope that's a little explanatory, just to kind of give a little bit more of a, let me reword that, just to kind of, talk about, give more awareness to the situation, kind of, so you can see where I'm at. Words are not working well with me right now. I'm just gonna cut this off. There you go. This is what happens when you give a woman testosterone. This is for 5 years. This is what happens, essentially. So, that's it. Stay safe.
A rising acceptance rate of transgender people has come hand in hand with rising rates of transgender identification, as well as in detransitioning. The decision to detransition was most commonly tied to the determination of gender dysphoria being related to other issues, health concerns, and the realization that transitioning did not alleviate gender dysphoria. This raises the question as to how useful transitioning is to helping those with gender dysphoria, as well as to the long-term efficacy of treatment regarding overall health. Despite the roles that they play in the decision to detransition, it is interesting that few studies have addressed the roles that internalized homophobia and living in an increasingly hypersexualized society may play in the decision to transition. Detransitioners often lack support, both from the community and from the healthcare providers that provided them with hormones and surgeries to begin with. The lack of medical follow-up and the lack of in-community support points to a concerning lack of knowledge on how to address those who decide that transitioning has not helped them and decide to desist from medical use. It also illustrates a desire to overlook the lack of ability to accurately determine who is trans and who isn't. This lack of support is not surprising. Detransitioners reflect the feelings of an ideology that preys on the young, idealistic, and mentally ill by promising a magical, quick-fix solution tied in with a strong community and sense of self, without ever addressing underlying reasons for gender dysphoria or the comorbidities that may cause it. It is because detransitioners once believed so staunchly in the gospel of gender and yet now reject it, that they are in turn hated so fiercely. It is one thing for a conservative or a radical feminist, often conflated to be the same thing, to criticize transitioning. Those are expected adversaries which are often rebuked and punished through threats of sexual violence and exclusion from academia and the workplace. It is altogether another thing for an apostate to do so.
If I'm being real, no one gave a fuck about detransition as a talking point until it started affecting straight women, because back when transitioning was seen as just an extreme form of homosexuality, and it was just like, oh, only gay people did that, it didn't matter because people didn't. Who cares about what happens to those people? But until straight women started complaining about it, no one cared. But now all of a sudden, you have all these straight women that are like, oh my god, I ruined my body with steroids. I ruined my beautiful feminine figure. I cut my tits off. My feminine, beautiful, high-pitched voice is gone. Now I can't please my traditional Christian husband. I just want to have babies, but now I can't because the trans cult indoctrinated me. I was just a poor, naive little girl who couldn't think for herself.
Gender dysphoria refers to a feeling of incongruence with the gender roles ascribed to one sex. Many choose to alleviate these feelings by transitioning to appear as the other sex, either socially, medically, or both. This can refer to such changes as adjusting pronouns to illustrate the gender that one identifies as and wishes to be perceived as, and changing one's name, known as social transitioning, as well as medical transitioning, which may include cross-sex hormones and surgery. Medical detransitioning therefore refers to the process of ceasing or reversing the medical aspects of one's medical transition, while social detransition refers to the process of changing or undoing the social aspects of one's social transition. Those who detransition may do so for a variety of reasons. Van den Busch, 2021, found that a majority of those who detransitioned did so because they determined that gender dysphoria was related to other issues, health concerns, transitioning not providing useful to dysphoria, alternative sources of solutions to dysphoria being found, or being unhappy with social changes, among others. Considering that transitioning is meant to alleviate gender dysphoria and that a majority of those who detransitioned did so because it did not serve this purpose, or because their gender dysphoria had other causes, it stands to question how well transitioning can address feelings of gender dysphoria at all. Of those who later detransitioned, a majority of the group had previously experienced both social and body dysphoria, with social dysphoria being defined as a strong desire to be seen and treated as being a different gender, and body dysphoria as a strong desire to have sex characteristics of the opposite sex or rejection of your own sex. Other factors may play into one's gender dysphoria, and these comorbidities are often left unaddressed. In other words, how are healthcare providers certain that they are treating the root cause of the issue and not merely treating its symptoms? Known as the intervention causation fallacy, it suggests oversight and a lack of research into the problem of comorbidities, given that over half of participants reported having had at least 3 diagnosed comorbid conditions, with the most prevalent diagnosed comorbid conditions being depressive disorders, anxiety disorders, and PTSD. The current form of treatment, known as gender-affirmative treatment, does not question if these comorbidities may play a role. Instead, they question the conclusion that the individual has come to, as they are supposed to be more sure of their gender than any clinician can ever claim to be. The theory of minority stress states that the frequently co-occurring psychiatric symptoms of gender dysphoric individuals are a result of prejudice and discrimination brought about by gender nonconformity, and that gender transition will ameliorate those symptoms. Under this model, all roads lead to Rome, and all individuals who've had problems can be attributed to being a part of the gender dysphoria. Ergo, treating gender dysphoria is seen as a way to successfully treat not only depression and anxiety, but to also resolve neurocognitive deficits frequently present in gender dysphoric individuals. It would seem evident that treatment which addresses comorbidities first should be investigated. But under this current treatment model, personal belief in diagnosis overrides other potential avenues for gender dysphoria. This may play a role in the long-term rates of mental illness and suicidality in this community. Instead of solving the mental health crisis, it appears that it may instead be perpetuating one. Current research illustrates that those who transition tended to have a higher mortality, including from suicide, as well as increased suicide attempts and psychiatric and patient care. Therefore, it becomes important to determine if these problems precede or follow the onset of GD and their possible relationship with gender dysphoria, as well as if other cultural, societal, and psychological factors may be influencing young people's identities and decisions to seek gender-related health care. Another issue with this form of treatment is the manner in which those who undertake it are not able to give informed consent. One study found that 45% of the whole sample reported not feeling properly informed about the health implications of the access treatments and interventions before undergoing them, with another third answering that they felt partly informed. Other ethical concerns have arisen regarding where much of the information regarding transitioning hails from. Particularly concerning are the erroneous assumptions held by professionals, poor quality of the evaluation process, and incomplete and inaccurate information that the patients and family members are given. Due to the sudden rise in those identifying as trans, there has been more pressure to treat those afflicted by it as quickly as possible, particularly as inaction in non-affirmative care is often seen as being part of transphobia and as playing a role in the mental health crisis of this demographic. In doing so, many individuals have been given hormones and other treatments without truly knowing the risks and benefits explained, including the lack of longitudinal research on the subject. This does not respect the concept of patient autonomy, as patients consenting to the treatment do not have an accurate understanding of the risks, benefits, and alternatives. Part of this support comes from the erroneous beliefs that questioning the reasons behind gender identity is inherently detrimental. However, the researchers from the study that popularized this take failed to take note of the use of a biased data sample, reliance on survey questions of poor validity, and the omission of a key control variable, namely subjects' baseline mental health status within their study. Other treatment options should be explored. There is little recorded research on non-medical approaches to gender dysphoria, as the primary method of addressing it has been and remains surgery. Because gender dysphoric children and teens believe that their lives will be immensely improved by transition, clinicians who have embraced the gender-affirmative model of care operate on the assumption that children and teens know best what they need to be happy and productive. This is a faulty assumption, as one would not use the same broadly supportive model to treat any other form of mental illness, such as an eating disorder. Instead, one would rightly question why a child or teen feels the need to lose weight and work towards resolving the underlying issue. However, given that hormone treatments and surgeries are drastic and have permanent effects, it is important to understand that there are other ways to address these issues. Particularly, detransitioners indicate that non-medical interventions for gender dysphoria are sorely needed, especially as the diagnosis of gender dysphoria and gender incongruence are constantly changing, as professionals disagree on whether the presence of distress is a key diagnostic criterion or is relevant. Resolving this gap in literature is important, as transitioning via surgery and cross-sex hormones can permanently alter the body and retains health risks, which can affect an individual long after detransitioning. There have been no tests to illustrate that the affirmative approach is better than others or how to measure outcomes in those studies. A lack of long-term follow-up studies reveals a gap in the literature as to how treatment works, or if there is long-term positive effects on mental health, which is the purpose of transitioning. Particularly, the rates of post-transition desistance, increased mental suffering, increased incidence of physical illness, educational failure, vocal inconstancy, and social isolation have not been established. In order to resolve this gap in the literature, there must be longitudinal research into the efficacy of different forms of treatment in order to ensure that those with gender dysphoria get the correct treatment, and that those who have other underlying issues which may present as gender dysphoria are able to be treated without resorting to surgical or medical options, which may have detrimental health effects and require detransitioning in the future if unsatisfied. A study like this will require a group which does intend to transition, and a group that is attempting to address their gender dysphoria in different ways, such as through therapy. Both groups should be contacted yearly to determine how they feel, health status, if they're continuing to transition, comorbidities, and if gender dysphoria is resolved. By doing so, one will be able to offer full knowledge of transitioning prior to making that choice, and will allow for informed choices to be made by those afflicted with gender dysphoria, which may help prevent the rising rates of detransitioning. The few studies which have completed a similar course of research have determined that long-term, transitioning leads to high suicide rates, disproving the idea that transitioning and acceptance within the gender community actually solves the comorbidities that often accompany gender dysphoria, which may be one reason that many researchers are hesitant to approach the subject. After all, surgeries and hormones are expensive. Long-term healthcare is expensive. Going to therapy and figuring out why you have those feelings a lot less expensive and a lot less profit to be found. This, dear viewers, is where we part. This video is basically an essay that I converted to a video script. I wrote it for class. It's, as you probably heard me mention a lot, a gap in the literature. It was a focus on the gap in trans healthcare. The background footage is from my trip over the water festival. I went to Siem Reap and to Camp Pot, which you'll be seeing footage of for probably the next couple videos because I have a good hour or two of footage. I hope this one wasn't too boring for you because it is very research heavy. All of my sources are going to be in the description. And if you join the membership thing on YouTube, you have a chance to read over the scripts in text form. Although I do admit I'm kind of interested in trying to convert some of these into a series of essays and to potentially publish it that way. So we'll see. If you have any comments, questions, or concerns, please leave them down below, and I'll see you guys next time. Bye.